I just wanted to say thank you, Dr. Abbasi, for your warm invitation. It's always an honor to be part of the collaborative discussion with colleagues. My name is Puya Ali Khani. I am a neurosurgeon at the University of South Florida. I did my residency and fellowship here. I did about 6 months of fellowship with Dr. Sukan Shah to learn about open deformity in Delaware. So I think it's a great opportunity to work with my with my orthopedics colleague to share some information and data. So thank you for having me. My case is about an spondyloptosis, so grade 5. Let's see. So my disclosure, I do some consulting work with DPU, but nothing relevant to this case. So a little bit of background on spondylolisthesis. It's an anterior subluxation of vertebral body, usually upper over the lower level. Mostly happens at the L5-S1 because of the shear forces that exist and sacral slope. And the second most common level is L4-5. There are many different types of them. This plastic that you see it in spina bifida and neuromusculars, in isthmic, in the pars defects. We'll see it in adults mostly due to the degenerative or even in iatrogenic after laminectomies. You can see it in trauma or also in pathologic fracture secondary to bony metastases and diseases. So the Myerding classification, as many of us know about this, grade 1 to 4, if it's less than 25%, up to 50, more than 50%, and if it's between 75 to 100%, which is level 4, and then grade 4, and then a grade 5 is a complete detachment of L5 over S1. So factors to guide our management, type and grading, spondylolysis, if it's because of the pars defect, how unstable they are, how flexible they are, what are the symptoms, is it only back pain, leg pain, and the level of fusion that we consider. So my patient is a 21-year-old female. She is a pharmacy technician. She has started to have back pain since 2015. She has little radiculopathy and is mostly back pain. She has had extensive physical therapy and injection. She has been offered multiple surgeries, but she had declined it for various reasons. Her pain gets worse with the standing and sitting, and now she cannot tolerate her pain. She's not able to stand. She was sent to the university by her community neurosurgeon for the management of her case. So these are her standing scoliosis. She has complete dislocation of L5 over S1 or spondyloptosis. As you can see, that blue box down there, it's her L5 that is sitting completely anterior to the S1 vertebral body. More imaging of her, sagittal images. As you can see, the L5 sitting anterior to S1. MRI. She has had complete no-access MRI to make sure there is nothing else missing, and so she has minimal radiculopathy, so her L5 working fine. It's just severe amount of back pain. So she has, high pelvic incidence, and there have been several of these papers and talk about this high-grade spondylolisthesis. And what do you do with it? How do you work it out? So it always comes to the balanced pelvis. If the pelvis is balanced, and what do I mean by that? If the pelvic tilt has not been increased, if the pelvic is not retroverted, and the lumbosacral junction is in a good harmony, you can incite fuse these people. But if it's unbalanced pelvic with an exaggerated pelvic tilt, secondary to retroverted pelvic, then you have to create more lumbar lordosis and try to reduce that L5 over S1 and then fix them. So if you look at my patient, her pelvic incidence is 85, her sacral slope is 52, her lumbar lordosis is 90, but her pelvic tilt is 36, so she is retroverting her pelvic. So our decision was to, I went back and forth, and I talked to a lot of my senior colleagues over, around the country, and some people were saying just go ahead and fuse her in situ. Some people were saying no, try to reduce her. And I think at the end of the day, I needed to reduce her a little bit to make sure, she does not develop adjacent level failure and PJK. So there are a lot of paper about the high-grade management of the spondylolisthesis. Surgical technique is either you can do A-lift, you can do T-lift, you can do posterior fusion in situ fusion. There's also a described Bowman technique. There's a reverse technique that talks about doing it anteriorly through the A-lift approach. You can do it through the sacral dome osteotomy. You can do complete corpectomy. So there are many different ways to tackle this. I have had several other cases like this that I tried to do an A-lift. That wasn't really a grade 5 or it was a grade 3. But sometimes when this high-grade spondy, the femoral vessel, the iliac vessel, specifically iliac vein, is stretched so much. And I have noticed during the approach, there's going to be a lot of chance to injury to those veins. So for the high-grade spondylolisthesis, I'm shying away from going anterior, and I do everything posterior nowadays. There are several papers that have been written on this. I don't think we can talk about those things later, but I'm going to talk about this case specifically. So these are her images, CT, MRI. This is the way that she stands up. As you can see, she tries to keep her posture in a good balance by retroverting her pelvic. She's increasing her pelvic tilt by pushing her pelvic back up to keep her head above her pelvic. This was our normal positioning. We started to do some traction on her legs to see if I can reduce her on the table, but that wasn't achievable. So these are my work process. So, posterior open instrumentation. I went all the way up to L3, and looking at it, hindsight, I could have stopped on L4. And being a younger surgeon, I felt more comfortable adding a next level up. I used reduction screws on top to capture my rod. Did a complete laminectomies, and we were planning to do navigation. I only navigated my L5 screws because it was very hard to find the pedicle of 5. It was sitting right in front of the S1 vertebral body. I put 2 iliac screws, one S2 LR screws and one iliac bolt on the right side. And the reasoning was that I needed to have a fixation. It has happened to me before when I did a complete laminectomy and facetectomy. The spondylolisthesis, the listhesis got even worse intraoperatively. Sorry about that. And I started to lose some of my motor. So in order to work simultaneously and make sure her shift doesn't get worse, I wanted to create a more lateral fixation while I'm operating. So we put the more lateral iliac bolt, and I put a rod, a cobalt chrome rod in. So I can keep her in place while I'm able to do my osteotomies and try to reduce her a little bit. Then we started to, reduce her slightly. As you can see, I put my screws, L5 screws only under navigation because it was really, really hard to find that pedicle. I was able to bring her to about between a grade 3 and 4. that was the time my L5 nerve would start to give me a hard time. I was using an MMG to see to monitor my L5 nerve root. That was after we finished complete bony removal to make sure while we are reducing her, the L5 nerve root doesn't get stuck in the sacral ala and sacral dome. So, I was able to find and pick up my L5 nerve root with 2 milliamp, but when that number increased to about 5, I stopped the reduction. So as soon as we stopped the reduction, I put the contralateral rod in and locked her in position. So then I needed the fixation across the L5 S1. It's extremely hard to put a T-leaf cage in that angle. There's not that much bone left, and the angle of it makes it very hard. As you can see, this is me and my fellow putting the L5 screws in, and look the way that I'm bending to just get the good trajectory for the L5 screw. So Professor Bowman has described this technique. It's a transsacral screws. What you do is you do a complete laminectomy, and like this middle picture, you can see it. You can do a complete laminectomy of S1 and S2, find the thecal sac, find the S1 and S2 nerve roots, and you pretty much start putting your drill right between the S1 and S2 nerve root at the posterior aspect of the vertebral body of S1, and you drill across S1 and L5. So as you can see here on the far left is a ball feeler. After we drill, I did it with the Midex, start with Midex, and then I use a striker drill to just go across the joint and across the disc space, and then I tapped, and then I tapped again. And this is you can see that intraoperative picture. The device is going between the S1 S2 nerve root, and my fellow is retracting the thecal sac more medially to create a slightly more room to protect the nerve root. You can see the suction is protecting the S1 nerve root, so all the nerve roots are protected. And the device that I found that I can put across it's a sacroiliac joint device. This is the device that I use to fuse the sacroiliac joint. The nice thing about this screw is that you can feel it, either pre-feel it or back-feel it with DBX, BMP, or whatever feeler you have as an allograft. So it's a great device to pack it. So that was the final product. We locked her in, and the device is holding her together because I just didn't want to feel it without any device between the L5S1. I've had cases that I just left them, and I was hoping that posterior in situ fusion will happen, and the rod broke, or the S1 had insufficiency, and we had an insufficiency fracture of the S1 pedicle. So she is almost 1 year out. She's doing great. Her back pain has improved. Her posture has improved, and so far she's happy, and she hasn't fractured any of her construct. So we'll see.
Well, that's